Thanks a lot, Dr. Kumar, for inviting me to your prestigious course, which is always so well attended. And my due in this is to talk on how I would manage a subluxated cataract in different situations and my reasonings towards it. And it's going to be a more simple presentation. Basically, when the lens is displaced from its normal position but remains in the pupillary area, it is called as subluxated lens. And when the lens is completely displaced from the pupillary area, it could be anteriorly dislocated into the anterior chamber or posteriorly dislocated into vitreous, where the management has to be strategized differently. The most important thing for us to see what is the degree of zonular weakness which is there in these cases, and with that we plan how we are going to approach it. But also we should also understand that what you are seeing on the slit lamp and what you see when you are open the anterior chamber and started the surgery, the extent of subluxation could be a lot more, and you may have to fixate the IOL to the sclera. The next important thing is to look at the degree of, besides looking at the degree of zonular weakness, it is also need to understand what is the pathophysiology behind it. Supposing it's an iatrogenic dialysis or a traumatic dialysis, you know it is not going to be progressive. You might escape with a CTR2 if the dialysis is small. But if it is a progressive dialysis like a pseudo-exfoliation or a Marfan syndrome, even if at that point of time the dialysis is less, it is best that you oppose it to the sclera at all costs. When you start the surgery, the very first step is how you are going to make your rexus, because look at that large area of zonular weakness. So there is no counter traction which is there on the capsule. So you have to place viscoelastic, high cohesive viscoelastic to flatten the anterior chamber, keep the anterior chamber formed at all times, go through the side port, start your rexus. Sometimes after a little distance of rexus, you can put capsular hook, which will give that extra zonular traction, and then complete your rexus, and which could be the different ways of doing it, but it has to be centered rexus, assuming that afterwards the lens is going to be, the capsular bag is going to be fixated to the sclera. Many of us would think of using a femto assisted surgery, wherein you can get customized rexus, but we need to know if it is a grossly subluxated cataract, a femto cataract platform will not do. The ways of stabilizing the capsular bag, you could use an iris hook, you could use a CTR, or you can use an Ahmed segment. Iris hook just gives an anteroposterior support, whereas the capsule segment gives an equatorial support, which gives a stretch right up to the fornices. So now I'm going to show you videos here. What's happened? Is the video running? Yeah, I made my side port, I've injected the dye. I start my rexus, but I find that I don't have that kind of tactile stimulus which is there if the capsule was not lax. So I very slowly start the rexus, but then I actually enlarge it also because I feel that it was fine. It wasn't that I was having too much difficulty, but I decided that I'm going to place capsular hooks. I want the capsular bag to be quite stable. I'm not going to take chances, but I'm not sure about the zonular dialysis. I go about my chops. Things are going well. But look quite carefully. I have completed my chop. Look at that small area superiorly, that area of zonular weakness. I go back and place another capsular hook. Because the vitreous has not come forward, I'm going to push back the vitreous, keep my phaco probe right in the center. But then again, there's a lot of nucleus matter, and I'm not too sure. So I decide that I'm not going to delay the placement of CTR now. I position my CTR, push it through the other instrument into the capsular fornix, keep my phaco probe in the center, ensure that my parameters are low, and keep bringing the fragments forward rather than me going deep into the capsular bag. But even then, somehow the posterior capsule looks very floppy, and I'm not too sure. I have brought my parameters down. I decide that I'm going to push my IOL now, because that is going to as a scaffold in this eye. And there is still a lot of cortex and even a small epinucleus, but these could be easily dealt with. I would have to just use the tangential force, and then I loosen my capsular hooks and complete the case. Now, this is an old case of ours where a patient had trauma and there's a large area of zonular weakness. But as I told you, these are non-progressive cases. So on a femto cataract platform, the rexus is done. I've done the soft cataract, a phaco aspiration. I've removed teased out the cortex. So here, I'm only placing a CTR. Incidentally, this guy has been coming for the last 10 years. But at this point of time, I think I would have placed a CTS also. Now, I'm going to show you another... this particular case again, right from the beginning, the capsular bag looks lax. there is some amount of phacodonosis, and so I decided I'm not going to take chances. I decided to do a supracapsular phacoemulsification. I am chopping the fragments. I keep ensuring that the endothelium is well protected, keep my IOP at 40. I keep ensuring that at no point of time the AC gets shallow, because small area of zonular weakness can increase. But the surgery is sort of got completed, and I have not yet placed a CTR, because I do not, the fact that the fragments are coming forward means there's no vitreous there. But look at the capsular bag, how lax it is. Do I place a CTR now itself is a choice. I push in viscoelastic, which stretches the capsular bag. If you place a CTR, sometimes, removing the cortex is a little difficult, because the CTR buttresses the cortex in the periphery, and there is no area of zonular dialysis. There's no vitreous there. So I thought, let us keep going on, remove all the cortex, complete the cortical removal if I can, keep injecting viscoelastic to stretch the posterior capsule, and then remove the cortex, and then only I place my CTR and complete the case. This then this is a case which has a larger area of zonular weakness. As I said, I need to ensure that my rhexis is centered, keep enough viscoelastic to flatten the capsule. But now, this case, a CTR alone will not suffice. So I put capsule hooks in that area of zonular weakness. And now I need to have adequate rotation, because there should be no stress on the zonules. Remove the stop and chop, complete the case. And in this particular case, I decided to place a sutured Sionis ring. I have to push it in the anti-clockwise direction and place the eyelet in the area of maximal weakness. I could have done a Hoffman's pocket, but here it is I have done a scleral, raise the scleral flap and do the railroading technique, and then suture the capsular bag to the scleral wall. This is one of those last cases wherein this is a case where there is a lens coloboma. There is a possibility of zonular weakness there, absent zonules in that area. I should have probably placed a CTR earliest after making the rhexis, because there could be fluid misdirection in these cases. But I placed my rhexis a little away from the area of zonular weakness, because there could be lack of traction in that area. This is a very soft cataract, so I phacoaspirate it and it all gets done in no time. And now I decide to place a CTR. I could have placed it earlier, should have too. I could have just left it like that, because there is a zonular weakness, but there's no dialysis. It could remain like that. But what happens is that area, the zonules are not there. There could be an asymmetric back contracture in these particular cases. So it sometimes makes sense to place an anterior Ahmed segment there and suturing it to the Hoffman's pocket. When there is very severe subluxation, I do not like to place 2 CTS and Sioni and any of those dramas. I've started feeling do very well with the iris clip lens. But this, of course, I would do a phacoemulsification and do it, but this was a very advanced dialysis, very advanced subluxation. So I make my incisions at a 3 o'clock and the 9 o'clock position, because that's where I'm going to enclave with the iris clip lens. Just checking looking at how much the pupil is quite small. So I use a Vectis and scoop out the lens and do a shallow vitrectomy. If the vitrectomy is adequate and you stain and you realize there's no vitreous, you need not even do a PI, because a pupillary glock is going to occur only if there's going to be vitreous. And after doing a vitrectomy, if the pupil is large, I would inject pilocarpine before I place my iris clip. But as the pupil was small, the pilocarpine is not placed, and I position my iris clip lens, and in the usual manner, stabilizing the optic of the lens, I go to the side port and push in the iris to get caught in the pincer-like haptics of the iris clip lens on both sides, and so complete the case. This was a patient wherein the patient came to me 6 weeks after surgery done elsewhere with diplopia, and he said that the CTR was placed and the surgeon had told him. But then I knew there was no choice. It was quite subluxated. I removed the IOL. But the message here is that there is a CTR there which has to be removed. So I go ahead and remove the IOL. But after I remove the IOL, I see there's capsular remnant. So I thought maybe the CTR could be there. Let's have a look. So as I pull out the capsule remnant, incidentally, to my luck, the CTR also comes out. But even if you're not able to visualize the CTR and you know the CTR is there, you should have your posterior segment surgeon remove the CTR and not just put an iris clip lens and complete it without bothering about a CTR in the back. And these are cases of late subluxations which can happen either inadequately treated primary surgery or a progressive zonulopathy, wherein you need your vitreoretinal surgeon to get the lens out and a glued IOL could be placed. So there are different ways with which you can skin a cat when it comes to subluxation. But the idea is we need to understand what is the kind of zonulopathy and treat it accordingly. Thank you very much.